right, hello everyone. It's a pleasure to be here, and it's an honor to debate Dr. Furman. I actually did my residency training at Cornell, and Dr. Furman was one of my early mentors on the wards, so I have a bit of a challenge ahead of me. But I hope to convince you today that FCR is still the best frontline regimen for CLL patients age 60. So just a few disclosures, research funding and consultancy. So often we face this conversation. Sitting across from us is a young, feisty patient who says, how are you going to get me to age 85, doc? I'm 60 years old. I want to live another 25 years plus. How are we going to do this? Where are the best long-term data? Toxicity, efficacy, all these things come into play. John McEnroe is not quite 60 yet, but he's getting close. So I thought that was a good example. There's been a number of different therapies used over the years in CLL for frontline therapy. You can see them here going back to the 60s with chlorambucil, which we still see coming up in some studies, with low complete response rates, not a lot of durability for chlorambucil as a single agent. In the 80s, we saw fludarabine introduced. We saw higher complete response rates, but not necessarily benefits in terms of overall survival in randomized studies. Even when adding Cytoxan, we didn't necessarily see that. So really the big advent was in the 2000s when chemoimmunotherapy became more popular. We saw much higher complete response rates, durability, and even overall survival benefits with FCR compared to FC alone. So now we've entered this very exciting era of the 2010s. We have lots of different agents to talk about, and we'll hear about a lot of them throughout the course of the session today. The CR rates are variable, and I'm sure one of the issues that will come up is how important is achieving CR in this disease. But I'll argue that I think it is still important, especially in terms of long-term disease-free survival. And so we'll talk about sort of how best to integrate these therapies into our current practice. So I'll actually start with an ibrutinib slide. We know that ibrutinib is a very active drug. It's well tolerated generally. And we have most of the data, of course, in the relapsed refractory setting. We have some data in the frontline setting that's been published, but not a lot. And these are a couple of the prominent studies that have been published recently with ibrutinib as a frontline therapy for CLL. And you can see certainly very impressive progression-free and overall survival curves. You probably can't see from the back of the room, but if you look at the number at risk here, as you get out to 18 and especially 24 months, the number at risk is about 3 to 5 patients. And so, these are just kind of early cuts of data at this point, and we don't know what happens 3, 4, 5 years out or beyond. So certainly promising initial results, even in patients with high-risk disease. On the right, we see the study recently published by the group at NIH, led by Adrian Wiesner, looking at patients with TP53 mutation or deletion 17p, which is our highest risk group in CLL. And if you look in the previously untreated group, in the line at the top here, the blue line, we see certainly very promising data at a relatively short time point. Again, only about 10 patients out here at 2 years, but there does seem to be at least some initial durability to response. We just don't know what happens after that. So I'll caution you to bear that in mind as you listen to some of the data that we present later. So what other options are there in the frontline setting? I'll just quickly go through this because I want to spend most of the time on FCR, but you'll hear more from Dr. Cheston in a little bit about obinutuzumab or GA101, the type 2 CD20 monoclonal antibody, now approved largely based on this CLL11 study, generally in older patients, where we see good response rates, about 80% in total. We actually see some MRD negativity even in the bone marrow, and we see a progression-free survival benefit over rituximab with chlorambucil. So I would say obinutuzumab is a very active antibody in the frontline setting for CLL, and I think it's an antibody that needs to be studied in combination with other agents. Chlorambucil is probably not going to be the most durable option for our younger patients. We have bendamustine rituximab, another chemoimmunotherapy regimen that's highly effective, generally well tolerated for most patients, high response rates in the German phase 2 data, about a 90% response rate with about a quarter of the patients getting a CR, but a median event-free survival only about 3 years or a little bit less, and certainly markedly inferior results for patients with the 17p deletion. So in Texas, more is better, bigger is better, and so Michael Keating and his colleagues put together the FCR regimen well over a decade ago now, and this has now been compared in a randomized phase 3 study by the German CLL study group compared to FC alone, and we see very high response rates, about 90% with FCR. We see high complete response rates in nearly half of patients, and we see probably the best durability of any regimen that we've seen so far with median progression-free survivals on the order of about 4.5 to 5 years. So for most of the FISH cytogenetic subgroups, it's a highly effective regimen. In particular, I'll note the patients with deletion 11q in the green line here, which historically have had inferior outcomes with chemoimmunotherapy. FCR does seem to overcome some of that negative prognostic factor of 11q, and those patients seem to have nice durable responses with FCR. Again, you can see clearly patients with deletion 17p have inferior durability of response to FCR. So one question before we get to ibrutinib versus FCR is, what's better, FCR or BR? Fortunately, again, the German CLL study group is helping us out here with an excellent study, the CLL-10 study, which we've now seen the final results presented on at ASH this past year. This is a large study, 564 patients, generally fit patients without deletion 17p, who are randomized 1-to-1 to FCR with standard dosing versus BR. And the primary endpoint of the study is progression-free survival at 24 months. This was a multi-country trial as well with 158 sites in 5 different countries. So we have a very robust data set from CLL-10. We compare FCR, about 280 patients, to BR, similar number. In general, these groups were pretty well matched, although there were more unmutated IGHV patients in the BR group slightly, which is a more aggressive form of CLL. But nonetheless, we see comparable overall response rates, 95%. We see high complete response rates as well, 30 to 40%. And some of the differences here that I think are notable, one in particular is the rate of minimal residual disease negativity in the bone marrow is significantly higher with FCR at about 40% compared to 30% in BR. And that translates into a benefit in terms of median progression-free survival seen here, 55 months versus 41 months. And this benefit really seemed to be most for patients who are under the age of 65. You can see a highly significant difference here, whereas patients who are over 65 did not really benefit from FCR, and you can imagine why. As we look in the toxicity area here, we certainly see high rates of neutropenia and infections. But when we dial down to where those infections were seen the most of the severe infections were seen, in fact, in patients over the age of 65. So I think few people would argue for using FCR as the first choice in that group. But in the younger group, we see still some infections, but a lower rate and no more than we see with BR, at least statistically speaking. One of the things that I'll point out about this study is that growth factor support was not mandated. So we see very high rates of neutropenia here, but typically in our practice we would use growth factor support routinely with FCR, and in our own data sets we see much lower rates of neutropenia. So that is one consideration with the neutropenia here. So why is minimal residual disease important? Well, it's really a nice window into the durability of response, both in terms of progression-free and overall survival, and this is held up now in several independent data sets. We can see here on the left side from the German CLL-8 study with pretty long follow-up now, getting out to 5 or 6 years. These patients who are MRD positive have a markedly inferior survival compared to patients who have MRD negativity. Even at relatively low levels of MRD negativity in even the 10 to the minus 2 to 10 to the minus 4 range, those patients do a lot better than patients who are truly MRD positive. And this has been upheld now in other studies. I'll remind you of the recent MD Anderson publication looking at their patients who actually had bone marrow biopsies after 3 cycles of FCR, and then again at the end of treatment after 6 cycles. And the most important factor in terms of the survival was MRD negativity. It's a little bit confusing here because there's multiple overlapping lines, but the blue, the red, and the green are all overlapping here with excellent overall survival going out now 4 to 5 years. And these are the 3 groups where MRD negativity was achieved, whether it was at the 3-cycle mark or the 6-cycle mark. Didn't matter, the key was that if you got to MRD negativity, you enjoy a very nice long overall survival after receiving frontline FCR. So I think some of the most compelling data from FCR are kind of coming from the early study. This is the FCR 300s, or one of the original studies from the MD Anderson group. And the advantage here is we have very long follow-up. And thanks to Bill Weirda for sharing this slide with me. He presented some of these data at the IWCLL meeting in Cologne a couple of years ago. And we see here a very nice plateau on this curve. If you look, about 40% of patients on FCR from that original study are progression-free, going out now on average 10, but even beyond, 12, 14 years, still progression-free at that point. So, some of those patients may be cured. We don't often think of chemotherapy or chemoimmunotherapy as curative in CLL, but I think these data would argue that perhaps some of these patients are. And I think it really is highlighted, especially when you break this down by the IGHV mutation status. So I alluded to this earlier, patients with unmutated IGHV have a more aggressive disease course. We see that here. But if we focus in on the patients with mutated IGHV, we actually see about a 60% rate of progression-free survival well out over 10 years, 12, 14 years in some cases. So a very durable response. You can take this with a little bit of a grain of salt, knowing that it's generally single-center data, a single-arm study, sort of the usual caveats of that. So I wouldn't necessarily go around saying there's about a 60% cure rate, but even if you cut it in half, maybe a 30% cure rate, that's still pretty good from FCR. And so I think for young patients who want an aggressive approach and are looking for potential for cure, I think this is perhaps a building block for studies that should explore curative modalities. And so, one thing that I'll highlight, and I would not debate this at all, that FCR is not the optimal frontline regimen for patients with deletion 17p. I showed you this graph before. Clearly, a poor progression-free and overall survival with FCR. In comparison, again, hard to compare across studies, but I don't think you could argue that it's looking much better for ibrutinib as a frontline therapy for 17p. It's now FDA approved in that setting, and I think appropriately so. So I would not necessarily advocate FCR. In fact, I would advocate against using FCR for patients with 17p deleted CLL in the frontline setting. So in terms of our future approaches to frontline therapy in CLL, I certainly think ibrutinib is going to be an important part of it, and there's ongoing studies that are going to inform that. I think one of the most important ones for our younger patients is the ECOG randomized study of ibrutinib with Rituximab versus FCR. This is going to be critical for giving us some of the head-to-head data that we need to actually make a true decision about which is the best therapy. We have some studies going on that are also very important for our older patients, the Alliance study looking at BR versus IR versus I, and the RESONATE-2 study, which has now completed accrual and we'll hopefully get some data on soon, again, for older patients. There's lots of ongoing studies now that are starting to look at novel agent-only approaches to treating CLL in the frontline setting. I just kind of say XYZ because I can't list them all. There's not enough room on the slide. So whether it's combining ibrutinib with monoclonal antibodies, combining multiple novel agents, kinase inhibitors together, BCL2 antagonists, it's really an exciting time to be able to eventually develop a novel agent-only approach to treating CLL. However, in the meantime, I think the data right now, as I hopefully convinced you, is still very compelling for FCR, particularly for these mutated patients, that we may already be curing some patients. So I urge you to consider not necessarily abandoning a therapy that we may already be curing some patients with, and maybe there's room for improvement. Certainly there is for patients with deletion 17p. And so one of the things we've been doing at our group is trying to think of strategies of how we can enhance FCR. Maybe actually, some of these patients who are unmutated or have higher risk markers, if they had exposure to a novel agent with FCR, they would actually have curative potential as well. And so I'll just attract your attention to a couple of investigator-initiated studies that we've launched at Dana-Farber. The first is a study of the gamma-delta PI3 kinase inhibitor IPI-145 in combination with FCR, so the two together in a single-arm study. This is for previously untreated younger patients with CLL. And the second is a phase 2 study of ibrutinib plus FCR for previously untreated younger patients with CLL. Two very similar studies. They both start with a combination of the novel agent plus FCR for the usual six-month time period. We're going to look at rates of MRD negativity at 3 months, and perhaps we might only need 3 cycles of chemotherapy with the novel agent in future studies. And then both of these studies have a period of maintenance afterwards with the novel agent to really try to maximize the rates of MRD negativity. And I hope that one of the novel aspects of these trials is that the primary endpoint of both trials is the rate of CR with MRD negativity in the bone marrow. And this will allow us to get a relatively rapid readout for the efficacy of these trials compared to the historical controls with FCR alone. And if that looks promising, it's certainly something we would explore in larger randomized studies that would be more definitive. So how are you going to get me to age 85, doc? Well, you could roll the dice with ibrutinib. It does look good for relapsed refractory disease. We do have 3 patients out at 2 years right now, so we could kind of put our money on that. Or we could look at this very robust data with perhaps as much as a 60% progression-free survival, well, probably a little less, but somewhere up there, with patients out with mutated IGHV at least many years, doing very well and in complete remission. So it's a little old school, it's a little conservative, but I would still vote for FCR for my young patient age 60. So thank you very much. All right.